السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. إن شاء الله اليوم نكمل حلقتنا عن موضوعنا عن التوبيك بتاع الكدني ترانسبلانت ريسيبيانت اسسمنت لأي عيان عنده اندستري رينال ديزيز ومحتاج يعمل عملية زراعة كده. نكمله. انت لما تجلس مع العيان بتوصل لمرحله الريسك ديسكشن بعد ما تكون عملت الورك اب بتاعك في الاكزامينيشن والورك اب عموما فروم انفكشن فروم كارديولوجي فروم مالجنس. بتوصل لمرحله ان انت خلاص بتوصل للريسك ديسكشن دلوقتي مع المريض. ايه الحاجات اللي انت ممكن تعمل ديسكشن مع المريض؟ نتوكل على الله. اول حاجه بتبدا بيها البري اوبراتيف ريسك، اللي خاصه لو كان عندك كارديوفاسكولار او مالتيبل كوموربيديتي. طبعا تكلموا هاي ريسك فور مورتاليتي كاردياك ايفنت سبيشال اسكيميا وات ايفر جاست انستيبل انجينا اور مايوكاردال انفاركشن اريزميا. DVT pulmonary embolism post-operative also if you have history of bleeding or clots. Bleeding transfusion also after surgery, especially some patient on aspirin and going to the surgery now. Our patient ran anticoagulation before, wound infection, dehiscence, and delayed wound healing, especially if BMI is too high, and diabetes and obesity, abdominal obesity. Pneumonia, UTI also is common post-transplant. Pneumonia is just to be sure your patient from day one, he receive incentive in spirometry just to prevent atelectasis and risk for pneumonia. And UTI also is common because this patient in two tubes in one stent between the ureter and the bladder, and Foley catheter is high risk for UTI. And post-operative pain, this will take a little bit some days to be recovered from multiple skin incisions, and the recovery, just his kidney function will take around 1 week to be recovered if he's working well after day zero from the transplant surgery. اميونو سبريشن، تعالى بقى البارت التاني هتكلم عنه. الاميونو سبريشن ريسك، الميديكيشن الريسك بتاعها انكريز ريسك فور انفكشن اوبورتونستيك انفكشن زي البي جي بي والسي ام في والبي كي parvovirus, all other viral infection. Increased risk for cancer, especially melanoma, skin cancer, and lymphoma. PTLD, especially if EBV mismatch, and side effect also included diabetes, especially with tacrolimus and steroid, high cholesterol and hypertension, especially with C9, osteoporosis and fracture, especially with high dose steroid, weight gain also from high dose steroid, and improve appetite after kidney transplant, and GI, nausea, diarrhea, from just maybe from just prednisone and especially from my MMF or Celcept, as we discussed before. Neurological tremors, headaches is related to tacrolimus also, and the remote donor transmitted infection also, maybe sometimes infection transmitted from the donor. Just as a point here for diabetes post transplant, the patient on dialysis, insulin distracted by the kidney, but the kidney not working on dialysis. Most of the patient diabetes controlled a little bit, sometimes just by diet, by oral hypoglycemic medication. But after transplant, he already the patient got working kidney function, destruction, more insulin with good appetite. All this need more diabetes control or medication or insulin, and also increase appetite also will make diabetes worse. So most of the patients they will need oral hypoglycemic or insulin post transplant. Graft outcome, you should speak with the patient while you are doing the workup in your clinic. Graft outcome and risk, rejection risk. Delayed graft function is common, especially sometimes with patient if deceased donor post cardiac arrest. Acute rejection may be also around, as we mentioned before, the percentage around 30%, and the graft function for deceased donor and around 1 to 5% in living donor. Also, graft failure also may be primary failure, especially if surgical problem. We have a lot. Living donor also complicated by thrombosis, twisting, and cyanosis the kidney and no more blood flow, and the kidney just explanted. Otherwise, just this is bad scenario. I hope no one faces this one. Expected outcome DSA negative with adherence. Just لو عندك دي سي donor specific antibodies negative and your patient is adherent to medication, one graft survival for living donor 95 to above 95. Just remember above 95%. Above 95%. Deceased donor above 85. 95, 85 to be easy for you. This is expected outcome if no DC and your patient is adherent to the medication. Live donor above 95%, deceased donor above 85%, 5 years, 80, 70. 5 years, 80% graft survival with the above 80%, above 70%. 95, 85, 80 70% for after 5 years graft survival for life and deceased donor. Risk for disease recurrence, possible recurrence of original kidney disease, especially for GN recurrence. I saw a lot of focal segmental atypical HS. All this IgA nephropathy, most of this disease can be recur after transplant. Risk dependence on diagnosis. What is the diagnosis for the primary kidney disease? And this will end by that depend on patient to patient, variant from patient to others. But you should discuss both one line for the risk of recurrence of the primary cause of intestinal disease. Post-transplant expectations, this you'll experience after transplant. You should be adherent to your medication. You will be in 3 pillars, 3 medication, tacrolimus and myfortic or Celcept and prednisone. Frequent clinic visits 3 times a week. Maybe you will come just maybe twice a week, 3 times a week, once a week, according to according to the protocol or center or hospital. And this will decrease with the time. And the blood work should be twice weekly. Skin staples will be removed 10 to 15 days after. Just intermittent first time, and next clinic visit should be removed all if you have good wound healing. Ureteric stent removal 4 to 6 weeks, not to 6 weeks, just 4 to 6 weeks. And this according by urology, and there is a surgery. And the drug coverage according to what will help this patient for insurance. اللي عنده تامين واللي ما عندوش تامين هم تبقى شور ان العيان ده هيعرف يجيب الميديكيشن بعده. complete age appropriate cancer screening after transit skin screening with dermatology and prostatic specific antigen, fecal occult blood or fit test for colon cancer. It should be regularly screened after transplant every 2 years. Regular follow-up with family physician also for any issue, for primary care physician. If any issue can be managed with the family physician, but don't interfere with the immunosuppression medication. Chair decision making, patient should understand that the risk and the benefit for transplant. You should repeat and ask the patient if you can tell me now. ممكن تعيد اللي انت سمعته مني او ممكن تكرر اللي انت فهمته مني. انت فهمت ايه؟ عايز اعرف انت فهمت ايه من اللي انا قلته لك. ممكن تخلي المريض يعيد to repeat what you said for him about the risks and the benefits of this transplant. And you should wishes to proceed with the transplant if your patient is a good candidate for transplant, and you can go in support by transplant team. And thank you so much. جزاكم الله خيرا على المتابعة، ونشوفكم على خير إن شاء الله بفيديو قريب. ولا تنسونا من صالح الدعاء، ولا تنسوا الصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. والسلام عليكم ورحمة الله وبركاته.